Good afternoon, everyone. Thank you so much for joining us. My name is Carrie Ann Vans, and I am the Associate Director of Graduate Admissions here at Bay Path University. And joining me today is our special guest, Dr. Vanessa. She's going to be presenting on a hot topic in healthcare, a day in the life of a PCP. Just a few housekeeping items before we begin. You may have some questions during the presentation, so please feel free to type them into the empty questions box in the bottom right corner of your screen, and we will have plenty of time at the end of the presentation to read and answer them. Let's see. So without further ado, I will stop talking and I will let Dr. Vanessa take it away.
Hi, thank you. My name is Vanessa Gadori, and I wanted to give a shout out to my old classmates in cohort 1. I am a graduate of Bay Path University, and we were all cohort 1, the first eldest child, as it were. Okay, let me see, give it a minute. Maybe more than a minute, there we go. There are times when I'm certain that many DNP candidates ask themselves why they started this program. Those of us in our cohort did. We had times when things were just very stressful. Tonight, I want to give you a small glimpse into the PCP world, which is the world in which I live, and hopefully inspire some of you to keep fighting. There's an expression in Thai, which is susu naka. This phrase means a lot of things, but my favorite way is to mean keep going, keep striving, and never give up. You are everything that you need to succeed. So I hope that you hold on to that and keep fighting. So this class will start at the end because the middle was too sad and long. The beginning was too long and complicated. But suffice it to say, I wanted to get my doctorate so that I could become a full-time faculty professor at Becker College, my original alma mater for my nursing degree. And the night before my doctoral interview with Dr. Cheryl Shiles, I was working a double on the cardiac unit at UMass Memorial Medical Center. I worked 3 to 11 and then 11 to 7. And I ran into one of the third-year residents who had just matched with cardiology, so we were having a little chat in the hallway. And I had let her know that I was going to a doctoral interview in the morning, and she said, "Hey, what are you wearing?" And I said, "Well, it's in the morning after this double, so I'm wearing this." And at the time, I was wearing bright orange scrub pants and a tropical Hawaiian print top. And she said, "No, you're not. You're going to stop at Target on the way there, and you're going to grab people clothes. You're going to grab a shirt that normally would be ironed and pants that zip, and you're going to dress up like you're going to a really important interview, because it is." And I said, "Well, I wore scrubs to my interview here." And she said, "Yeah, that was to be a nurse. You're going to be interviewing for something more prestigious. You have to dress the part." And I'm really glad I did, because when I got there and I met Dr. Shiles, she was dressed immaculately and she looked like a presidential candidate. So I'm very glad that I dressed the part. But the combination of having not slept and the fact that I had undiagnosed ADHD and her office full of sparkly things, it was kind of an unmitigated disaster. There was about an hour of discussion during which she asked me continually what my framework was, and I at the time didn't know what that meant. But there were 5 good minutes where I talked about what it was I wanted to do with a doctoral degree, and it was not become a primary care provider. That wasn't on my horizon. And actually, I did get accepted, clearly, and found out that it was a DNP-FNP program. But at that time, I thought that meant that there were DNP people and FNP people, and at one point we would part ways, and some of us were going clinical and some of us were not. And it wasn't until almost a year into program that I found out that I was going to have to go to clinicals. So I thought that that discussion didn't apply to me. But the beginning and the middle were tough. And some of you that are already in program, you know what I'm talking about. It is hard. A doctoral program is not a cakewalk. It's very hard. It takes a lot of dedication and passion and commitment to make it to the end, but it is so worth it. So Let me try to inspire you a little bit. So this is the end. This is what you're striving for, is the fun hat and the doctoral robes. I don't have anything else to say about what the end looks like. This is what it looks like. Very happy. And there's all of us. This is my whole cohort. 5 of us graduated. We had a bigger class when we started, but that's what we ended up with. This is the end, sort of. This is what you're kind of striving towards. Okay, when you walk across the stage at graduation, you're actually not quite done yet. You are still finishing the back end of your project and your defense and your final paper. You will learn things during that time that you don't realize you'll learn until years later. The most important thing I learned during the process of my doctoral project is this: Captain Jack Sparrow was right. The problem is not the problem. The problem is your attitude towards the problem. And I think what I can say is that things will always go wrong. It's not about whether or not things go wrong. They will go wrong. It's not about the didactic or the theoretical, pedestrian, anecdotal, or otherwise. It comes down to you and what you're going to do about where you find yourself. It's important to let go of should and if, because the problem isn't the problem, and it isn't about what should have happened or what could have happened. The problem is getting yourself into the right frame of mind to be effective in the problem. Everything I do in my day is about addressing a problem that needs to be solved. Every single thing I do is a problem that has cropped up. And I had no idea that during my time at Bay Path, ultimately what I was learning was how to maintain a curious and passionate mental framework in order to withstand the onslaught of problems that were demanding to be solved with life-altering consequences. Your attitude towards where you find yourself will help or hurt you. So it's really important to maintain a good sense of self. Okay. So what can I say about boards? First of all, you're in program now or you're thinking about it, and I would suggest start doing practice questions now. Just like you did for your original nursing license, boards are not like the NCLEX at all. The NCLEX questions are set, analyzed, validated, and verified by several 100,000 students before they become real test questions. The board, it's not like that at all. It's written by a small group of individuals. It's possibly vetted. I'm pretty sure it's vetted. I'm pretty sure it's analyzed, but it is not responsive to your responses. Like the NCLEX is changing what it's going to ask you based on the way you answer. Boards are not like that. You will do all of the questions, whether it's 150, 180, 380, you will do all of those questions. So it's important to temper yourself to be able to sit that long to do all those questions. I don't know what the statistics are for boards, for the NP boards. I didn't look them up, and I struggled because I wanted to be able to footnote something here, but I'm gonna get through this presentation without having any references whatsoever. And you have 2 boards. There's the AANP and the ANCC, and if you're a member of ANA, the ANCC is part of that. And I'm going to be really honest, if not a little bit scary. I'm probably the only one you're going to hear be honest about this, but I did not pass boards on my first attempt. I did study, but there's a lesson here. I can show you the evidence of my studying. I went through a 50-hour course twice, and I can actually mimic the guy who did the course. I can do a pretty good impression of him even years later. But I spent more than 250 hours studying. I took a lot of time off of work, and I waited until October to test. Don't do that. Test as soon as you're able, okay? You are not going to get smarter in the interim. You're not going to know more in the interim. You know what you know, and you do know enough to pass that test when you graduate. So test as soon as you can. But secondly, my mother had recently passed away, and I thought I was fine, but I could not have been, because there's something I've been telling nursing students for decades, which is never change your answer. Never change your answers, never change your answers. In fact, on my first attempt for NP boards, I changed 6 of my answers, and later on we figured out that I had failed by probably about 4. So do not change your answers. Don't change your answers. And that's all I can say about boards, except that I passed. I did pass, so here we are today. All right. Becoming a new provider is a huge transition, and it takes about 2 years. I know that sounds crazy, but the transition is profound. For one, you're it. All of a sudden, it's the all about you show, and not in a good way, not in a fun way. Everything you have ever learned, experienced, every job you've ever had, every interaction with another person, every interaction you've had as a healthcare provider in any capacity has been bracing you for this, because you're going to be providing care to human beings. You're going to be helping them recover, helping them heal, helping them stay well, and hopefully helping them live their best lives possible. The point is not to panic. It's important to have a lot of good connections. Start making them now with the people that are in your program, the people that you interact with, preceptors. Make good connections everywhere, because every single person you know is a lifeline on a day when you don't have the answers, okay? In the early days of practice, hopefully you'll find yourself here. This is Family Health Center, and I'm very thankful that I got hired here before I ever even graduated. There is so much care given to brand new providers. You will shadow people for about 2 weeks before you're expected to start. You will be under a senior physician, a supervising provider. You might even do a residency. They have residency here. I did not, but I'm kind of in a residency in that I have a supervising provider, and I am choosing to stay with him for a 3rd year. After 2 years, you can enter independent practice in the state of Massachusetts, but I chose to stay with them for an extra year. And part of that is because actual MDs that want to become PCPs, they have to do 3 years of residency. So I feel like the 3 years is reasonable. In the very beginning, everything feels like the most complicated case you've ever seen. Everything feels like that. You have to ask questions about everything. And I remember one situation, the head of this whole facility happened to be walking past me, and I was running, and I had an EKG in my hand. And he said, wow, what's going on? Stop, tell me what's going on. I said, well, okay, well, the patient's bradycardic, and they're having this, and they're having this, and this is their background, and this is what's going on. And he looked at me and he said, okay, what does the patient look like? And at that moment, I realized I hadn't even gone in to see the patient yet. So I said, hold on. And I ran back to my clinic exam room and went and saw the patient and realized it was not dire at all. That's where they lived, and we moved on. So, you know, everything feels scary at first. If you're in a good place, there's lots of people to ask. There's always someone here to ask. And that's what's important in a good primary care site when you first start, is to make sure that you're not in an office by yourself trying to make these decisions alone. Make sure you're surrounded by people. And I feel like the most important thing is to become competent, not confident. Competent means that when you're struck with something unfamiliar, you know who to ask, you know where to look, you know where to go. You don't have all the answers, and you never will. The important thing is knowing where your resources are, what time of day it is, all those kinds of things, okay? So a day in my life looks like this. The population of Worcester County has quite a large cultural footprint. The most frequent language translation required is Spanish, Portuguese, Haitian Creole, Arabic, Albanian, Vietnamese, and Pashto. And I just said a whole lot of languages that most places aren't going to have that many translators. So we do use a lot of that telephone that's behind me, and there's a key card beside it that tells you where you're dialing to get different languages. We also have a large population of people who are refugees, and they bring a very special set of needs with them. You know, consider, for example, a patient arriving from a war-torn country who also has, you know, hypertension, diabetes, untreated forever. These are really serious concerns and things that we have to address. They might also have trauma, so that's important to know. Here in this clinic, we also treat gender affirming care, LGBTQ care, reproductive health, substance use and abuse with MAP. We cover everything from birth to death, and within each of those populations, there's niches that have to be taken care of. For example, the hepatitis team or the HIV team or the hypertension team. We have individual teams within that. There's quite a bit of overlap within these populations, and so patient-centered can get very specific. And talking about the language barrier, we have about 60 to 70% of our visits that require a translator. So that means time. Everything that's going to be said has to be said twice, and you have to learn how to work with a translator. I am hit or miss at times. I have rattled off way too much information, and it's going to take them time to translate all of that. But what if you feel like the translator didn't say what you said, or you asked a yes or no question and you get a response that's rivaling the Iliad? Both of those things happen, and they happen every day. There are times when I've said about 30 seconds of information and the interpreter takes only 12. And I know that everything doesn't take the same amount of time, language to language, but there are times when I am really aware that what I've said did not get said to the patient. And that matters because it means the patient has less of a chance of following my instructions if they didn't get them in the first place. So, you know, sometimes you do just say, you know what, I'm going to call back interpretation later, and you will hang up and you will call them back and hope for a different interpreter. So sometimes that has to happen because it might be crucial that the patient understand exactly what you've said. Okay. One of the things that I also do is I take the time to print out my instructions in the patient's native tongue. And since I've never gotten a translator to commit to translating my stuff for me, I do use Google Translate. And I just preface that with the patient by explaining to them, look, I'm using a service to translate my instructions, and some things may come out crazy. And when they hear that, they usually laugh because they understand, because they've worked with it themselves. And so it's a good bonding moment that we all don't know what we're saying, but you know, we do our best. And what can I say about una pregunta? I don't know why, but even though I'm very clear that I can only address one concern in a 20-minute visit, I will always have una pregunta and un otra pregunta, multiples, and they're all going to be separate concerns. They're all going to be very complicated, and typically the most egregious of their symptoms will be the last thing they said. So oftentimes the translator will say to me, by the way, it burns when I pee. Well, that's more important than everything else we just talked about. And so it is going to make the visit take longer because I can't not treat that. I can't not address that. Or they might say, by the way, my chest hurts sometimes, or I almost forgot to tell you, I haven't had my menstrual cycle in like 2 or 3 months. So these are aspects, daily aspects that will impact you every single day. I am a little bit rare in that when I leave the room, my note is done. I know a lot of people that use transcribers, or they use scribes, or they use a service, or maybe they just didn't feel like they had time to write out everything and they're going to do it later. But I fortunately had the experience in clinical of working with a preceptor who started every Monday -10, and watching her struggle to get these very complicated notes done made me very aware that I really needed to type faster. So I can type between 150 and 200 words a minute. It's not technically perfect, but I tend to face my computer to the patient so that they can see me, and I will type and stare at them. I've learned how to type without looking at my hands, so I will type without staring at them furiously to get everything done in the visit, during the visit, so that I'm not having to go home and do more charting. It has happened on rare occasion. Sometimes you can't help it, but it's really important to not leave things undone, because you cannot catch up once you get behind significantly. One of the things that we found is there are certain times in your life, like I have already had all my kids. I am way older than I look. I'm in menopause. I don't have young people at home. So I can stay later and just make sure all my notes are done. That's not possible for everybody. So you always have to be thinking about your own circumstances and get done what you can done in the way that works best for you. Okay, that's primary care. I also work urgent care. What it's supposed to look like is urgent concerns that if left unaddressed, it could lead to serious harm, like it hurts when I pee, or I cut myself doing this. If they have a chief complaint that could be an indication of a life-threatening issue, they really need to go to the emergency department. And we send out from here probably about 6 to 10% of our urgent care visits do get sent out to the hospital. One rule of thumb is if you were stung by 1 to 5 bees, you might go to urgent care. But if you got stung by 10 bees or more, that's the emergency room. Another example is if you're in your yellow zone for asthma, that could be urgent care. But if you're in your red zone, that's the emergency room. Okay, now what it actually is I've had people come in for med refills. I have also diagnosed a STEMI. I've had multiple MIs. I even had a positive cauda equina, which is an emergency. There have been a few strokes, a serious pressure injury that had gone septic. So that is not the most of what we do. Remember, that's only 6 to 10%. The most of what we do are these chronic conditions where they couldn't get an appointment to see their primary care provider for so long that they've run out of medication. And that becomes an issue because, well, they were on the medication for a reason. So one of the dangers of too many non-emergent cases in urgent care is that you can sometimes get lulled into complacency. And the adage is, if you hear galloping, look for horses, not zebras. But that only works if you're not on the African plains or not standing in a zoo. And sometimes you're in one of those places. So balancing the art of saying no and please don't die becomes very important. And one thing that's very true of nurses and most healthcare workers is, even as we step into higher degrees, is that we tend to temper our experiences with dark humor. That piece of nursing life never goes away, and the best tip I can give you about dark humor as a coping strategy is to never let it be part of your forward-facing practice. So that dark humor stays well behind the scenes, locked in the charting room, and should never, enter the exam room. Part of the balancing act you're doing is balancing between no and please don't die. You have observed a lot of providers. You have to spend a lot of time with a lot of providers and to figure out where you are on the paradigm of, is this treatable by me right here, or does this person need a higher level of care? Is this something that I should be treating, or should I be bouncing this back to primary care? I tend to be very easygoing. If they stood in line for 2 hours at our urgent care to get a visit, I tend to address their concern, mainly because if I don't give the diabetes patient their diabetes medicine, they're going to be in an urgent situation quickly. So I'm balancing a lot of things, not the least of which is trying to make sure I'm not creating an urgent care visit or an emergency room visit. So those are some things that I do during my day. Now, politics and primary care. I've always been moderately disinterested in politics. And what I mean is, if somebody were to bring up politics, I would put my fingers in my ear and start screaming no. Kind of like discussions about spirituality, morality, public policy. These are very polarizing topics, and people can have some very sharp opinions and beliefs about these things. You don't need a PhD in sociology to appreciate how divisive these things can be, as you've watched the world over the last few years, you know this yourself, the intersection of primary care and politics does not feel like a crossroads, it feels like a car crash. You are going to encounter the oppression of politics in primary care, from systemic racism to blatant abuses of power to just things that are confusing, just don't make any sense. You have to navigate the labyrinth that is the US healthcare system in order to take care of your patients, and it can get bleak at times. It's very easy to succumb to it, but you can't because you're holding the line. It's you. You don't have to agree with the status quo or even agree with the policies that are in effect, but you do have to take care of your patients. You'll notice that one thing that you can get done during one administration, you won't be able to do in another. No political party has ever seemed to embrace the truth that dead people don't pay taxes. Any politician can have their views, and they're going to have their impact on public policy and healthcare policy. So currently, we have someone in power who has decided that fluoride is deadly at any level, and it makes it difficult for us to get the fluoride we need to do the treatment on children's teeth. And this same population may never see a dentist, so the only protection they're going to get is teeth brushing daily, hopefully, and the fluoride that we paint on them at their well visits. So it's really important for us to be able to provide that fluoride treatment, and you as a provider have to come to a place where you appreciate and don't lose your mind when we can't get it, because there are going to be times when we can't get it. And this is fluoride. This is a simple thing. And I chose it specifically as a good example because there are a lot of other examples that are far more damaging to our population that I could have used, but that brings us into a conversation that we don't want to have tonight. This is a part of your practice. You have to be aware of these things. You have to be aware of politics in a way you probably don't want to be, but awareness helps you take better care of your patients. And so that awareness allows me to be ahead of the game and to be ensuring that I'm doing my part to help my patients stay safe. It's frustrating. It is very frustrating, but you know, this is where you find yourselves. There seems to be a wave of distrust of intelligence combined with a wave of worship for popularity over common sense. And it's almost as if high school vomited across our country. At the very least, we're living through the love child of Animal Farm and Lord of the Flies. It's very easy to get lost in politics and lose sight of what we're all trying to do. But we can't lose sight, and we are among the most educated people in the country. And we need to bring our A game to the table, because it doesn't matter ultimately what politics are in power. We're still going to have to find creative ways to solve the problems that we face. We need to get patients the scientifically sound and accurate information that they need to make the best choices for their lives. We need to do this in a way that ensures that the patients will listen to us and that they'll consider the information we're giving them. We need to keep the patient-centered piece as the focal point of our practice, and it does make navigating these crossroads easier if we keep it patient-centered and let go of all these other pieces. You will find in any place, in any building, it doesn't matter what it is, healthcare, education, you know, stock market, whatever, it's very easy to catastrophize. You have to avoid that and staying away from people. So now we get to the fun part of my daily life and what I do, which is the procedures day. Okay. So my favorite thing is procedures. I love procedures. I don't normally get a day of procedures, which is what I would want. I normally get procedures sprinkled throughout my schedule, but I've been begging them, can you just give me one day where all I do that day is procedures? And I think it would be great to be a Friday, because it would be great to end my week on procedures. But so you have some topics there. Well, that felt weird. When you go through Nexplanon training and you learn to put in a Nexplanon device, you're going to practice on this rubber arm thing. When you do it for real, that's a human being, and it's unsettling the first time. The first time you place that trocar at the 30-degree angle near the skin, near your marked location, and ensuring that the patient is numb, you're going to have a pause where you're just rationalizing with yourself that you're going to puncture this into their skin, and then you're going to go shallow, and you're going to lift up their tissues hanging on this meat hook looking thing, and you're going to shunk it forward. And it doesn't glide like it did in the plastic arm because it's getting hung up on adhesions and connective tissues. And so you're going to be kind of shuttling this thing forward. And it feels weird. And the whole time you're doing it, this is a human arm I'm doing this with. It's weird. It takes you around 15 or 20 minutes to set up, but the placement takes 20 seconds. And as soon as you press that lever to release the device into the tissues, it retracts the trocar, and all of a sudden it lets go of the skin, goes down, and you're just left holding the device. It's a very weird moment. You stare at the hole, seeing the placed device in there, mixed with subcutaneous fat. Maybe there's some blood. Sometimes there's a lot of blood. Sometimes there's just a little drop. Then you start to wrap their arm in a pressure dressing, and the patient will look up at you surprised, like, that was it? And you're done, and you're going to be like, yeah, easy, wasn't it? Like, you know, like, yeah, that was easy. But you will reply as if your heart hasn't been bounding against your ribs like a rom-com character. But it will be, because that was the weirdest thing that you've done so far in your life is, you know, put this thing in, and, you know, you leave the room looking like you're confident, but inside you're just like, blah, that was weird. I suggest practicing that a lot with your arm. Once you practice it a lot with your arm, take one chance to grab a chicken leg or a chicken thigh and practice it before you get to humans. Practice it in a chicken leg or a chicken thigh. You got to throw the whole darn thing away when you're done because it's contaminated now. And if you can, get a sharps container because it's now contaminated with chicken. But practice it in actual tissue to get what I'm talking about so that you can be kind of grossed out on your own. And the next thing is I don't place IUDs. I've attended the class, I passed the class, which you have to do on a computerized lady, as it were. But all I have to do is place an IUD with an observer, but I'm not going to, and it's because of the word tenaculum. And a tenaculum is a tool that you have to use, and I'm not going to. That's going to be a no for me. If you get bored later, and later on in this presentation you're going to see a trocar, I'm not grabbing anyone's cervix with a medieval torture tong. Imagine just a giant set of pickups. And when I went into the class and I saw those, I actually didn't know what they were. Yeah, I place a lot of Nexplanons. Okay, so my last favorite procedure is an irrigation and drainage. If you don't know, it's called an IND. We handle a lot of different kinds of cysts. There are whole populations of people that are just very cystic. They make a lot of cysts. During my first attempt at an IND, I was very excited, and partially because I used to watch a lot of Dr. Pimple Popper, and I felt like this was something that I was going to be really good at and I was going to really enjoy doing. I'm good at it now, but I didn't do it at all for a while because of my first experience. During my first procedure, I had to leave the room, and that's because I had never cut human tissue before. I had never used a scalpel on someone's body. Even when you're removing a Nexplanon, you're not making an incision, you're darting. You dart, and that's how you take out a Nexplanon. You don't cut so much as poke. For an IND, you are making an incision. You're doing it on purpose, and your instincts are going to be wrong because instinctively you're thinking saw. So you're thinking you're going to saw back and forth. That's not what a scalpel is. How you're supposed to do it is with abject competence and steeled nerves. You press down on the scalpel and in one smooth motion draw it back across your surface. scalpel is a slicer, so you're just going to draw it back. There are no teeth on scalpel blades, which is why it's not a saw. For me, I was opening a cyst on an axilla, and I did my best to do what I described, but as soon as the scalpel hit the tissue, the way that it felt through the scalpel into my hand was a sensation that I wasn't expecting. It wasn't at all, I don't know. I don't know what I thought I was going to feel, but when I did it, the vibrations felt a little bit like filleting a fish. And for some reason, that caused me to turn green. And my buddy, Kirchi, who was with me, who was observing me do this for the first time, said, "Oh, hey, this one looks like it might be a little complicated. Let me step in for you." And she stepped in front of me and she took over, and I said, "I am going to go get some more supplies." And I stepped outside of the room, shut the door, and promptly chucked my guts out. Yeah, something about the way that it felt. So my recommendation to you is a hunk of either a chicken leg, a complete leg thigh combo, or because it's nice and big, or if you're not have a pork aversion, you can get a pork butt and you can practice on that, practice, making that nice smooth incision. Now I'm very good at INDs and I'm good at sutures. I love throwing sutures. I love learning new tricks and new ways of attaching skin to where it was supposed to be in the first place. And now that I know what tools feel like dragging across skin, it doesn't even bother me at all. I don't even have to think about it, but it took a while for me to feel comfortable. So those are my activities that I do on any given day. And this over here on the far right, that is a trocar. So if you want to feel good and creeped out, that's a trocar. And that is it. So for questions.
Thank you so much, Vanessa. That was extremely enlightening. When it comes to all of the different things that you experience as a PCP, there's never a boring day, I'm sure.
Nope. I long for a boring day, actually. I long for a day where we like, oh, it's so quiet in here.
I know, which you're never supposed to say, right? Because
Nope,
that means
not supposed to say. We'll all think it.
Yeah, exactly. Okay, so let's see. The first question that I'm seeing that came through is, how can a DNP make a meaningful impact in primary care setting from your perspective?
So that is a great question because there is a lot of misunderstanding the difference between an NP who has achieved their master's degree and an NP who has a doctorate. And the difference there is a difference in approach, not in the clinical setting, but in the problem-solving setting. And I'll give you an example. Recently, we were trying to understand what is possible in urgent care. Can a provider see 3 patients an hour, or should we stick to 2 patients an hour? And that doctorate that I have in my brain said, well, we should study it. We should understand more through gathering evidence. And so I did a pilot project where I saw 3 patients an hour for 2 weeks. I documented everything, documented what kind of visits we were getting, who needed interpreter services, were we getting a lot of chronic visits, were we getting things that really couldn't be handled by us, and how long did it really take us? And that led us to understand that it takes about 30 to 35 minutes per visit in the walk-in center, no matter what they're there for. The average length of time for a visit is 30 to 35 minutes. And so that has a bearing if you're going to try to change policy. That doctorate enables you to think about things not in terms of anecdotal evidence. Anecdote meaning, well, I don't think I could see that many patients an hour, or I think I could do this. Instead of thinking like that, that doctorate gives you the opportunity to bring the research part. Oh, I know how to do this. I know how to look into this as a problem, or I know how to look into this solution and see if it applies to this problem, and we can study it in this way. That's where the doctorate helps you out, because you've already done that. You already know that you can't just say it's going to take this. You know how to kind of go into the background and what do other practices do, and how has anyone else done this research, and do a lit review. All of those things just come forward, because for the master's person, they only received the clinical portion and a very light dusting of translating research into practice. They did get that full clinical piece, but for the doctorate, we got more of that research, translational research into practice, and understanding how to dissect a problem, those kinds of things. So the doctorate helps me understand how am I going to figure out what the best way is to move forward with this problem.
Great, thank you. And then actually the second question is an excellent segue. Have you been involved in any quality improvement or research initiatives?
Yes, so I did do that initiative to try to determine if it was going to be safe to increase patients per hour visit. The other thing that we're a part of right now, that I'm working on right now, is Ballant Group, which, if you don't know what that is it's a group that's meant to help providers in a group setting kind of cope with challenging situations, such as the climate we all find ourselves in, which is the nicest way to put that. But we may actually have to just see 3 patients an hour. We may have to increase our throughput, and we're going to have to find ways to make that happen, because this healthcare facility services 46,000 people, and its capacity is about 26,000. So we have to figure out a way to get the patients seen that need to be seen. So a Ballant group is kind of like a peer support group, for lack of a better term, and I'm helping to make that a possibility here. It's tough. So providers need to be able to come together and help each other cope with the situations that we find ourselves in.
Great, thank you. And the last question I'm seeing come through is, what health policy changes have directly affected your clinical practice?
So most of the changes that I'm experiencing are not direct on us. They are direct in other states, in other places, on other populations. So for example, if a governor of one location decides to capture refugees and transport them to another state, that other state can't then just give them back. Those people have to be located, basically rehomed, for lack of a better word. They have to be given housing and shelter and medical care. And so our already overburdened Massachusetts healthcare system has to bend in order to provide that care. And that means seeing way more patients than is comfortable. That means seeing patients whenever they show up. So appointment times are non-existent. If they show up 2 hours late, we really need to see them, because we may not ever see them again. We need to provide that care. In addition, the states that are blocking birth control create a problem for the states that provide it, because people need to have access to it. So I do a lot of reproductive health visits. I do place a lot of Nexplanons. And sometimes we are tasked with having to take care of people who live here, but they don't really live here. They live here because they're documented as living here, but they may not actually live here. But we need to provide that care, because where that person might be coming from may not be a place where they can get access to that kind of care. So it impacts us in a way that we need to do more visits than we ordinarily would. We need to provide a lot of extensive reproductive health care. And then directly, for example, not being able to get any more fluoride becomes a problem. Last year, the companies that manufacture Ella and Plan B sent us a lot of doses just for free. They just sent us these things, and we did not get any this year. So that impacts us in terms of being able to provide emergency contraception to people who need it, but maybe can't be documented as needing it. And I will describe, like, perhaps someone who's living in domestic violence, somebody whose religious beliefs forbid them from doing, these things. Like there's lots of reasons why somebody wouldn't be able to just go to the pharmacy and get Ella or Plan B, and they need to be able to have it available for them, or they may be in a situation where they're going to be compelled to have a child that they're not really wanting to have at that time. So there's a lot of reasons why the laws of other states will impact us here in Massachusetts. Not having access to those free samples is a problem, and not having ready access for lots of people in all over the country to birth control is a problem. And it's the deserts, the healthcare deserts are a problem. So all of these things will impact us here in Massachusetts because people will seek out the healthcare, and if they have to move, they literally will move. They will move to Massachusetts to get that care because everybody needs healthcare. So, yeah.
Absolutely. Thank you so much. Those are excellent questions and great answers. That concludes our questions. However, for anyone watching who is interested in becoming a DNP, and this sounds like something that you might want to do, we do offer a DNP with 2 entry points, one from a BSN to DNP-FNP and a postmaster's DNP. We also offer an MSN. All options you see here are online and asynchronous. And please feel free to contact myself. That's me and Dr. Linda Adams-Wendling, the program director, and I am always happy to chat with you about the program or the application process. And thank you again so much, Dr. Gadori, for presenting this evening and for taking time to answer questions. Thank you so much, everyone. Have a fantastic evening.